Good evening, one and all. Thank you for coming in on time, ahead of time. Please stay 2 more minutes, 1 or 2 minutes more. Let's stabilize the Zoom platform and the YouTube live. We will be starting immediately. Welcome to the last program of Exam Alert. Give us a couple of minutes more to enter everybody. Good evening. So happy to see so many familiar faces, so many familiar names. Videos are not on, so I can't see much, but very familiar names. Thank you so much for trusting online industry, coming in for each and every program of ours. So there are some names which was there with us right from lockdown beginning onwards. I can see certain candidates. Thank you so much for the support shown to online industry and its programs. Me a minute more. That's it. We'll be starting in a minute's time as soon as the waiting room gets stabilized. Zoom is getting stabilized. Yes, we are good. Right. Good evening. Welcome to Online Dentistry. Online Dentistry firm started way back in 2008 with the motto redefine dental education. We are doing exactly that. We changed the way dental education is happening for dentists, for practitioners. Then we moved on to postgraduate training. Then now we are into undergraduate training. That's what you're listening today. That is finally a exam preparatory help called as Exam Alert program by Online Industry is what you're listening to today. So online industry started way back in 2008. It is not a new firm. 12 years before even the whole concept called online became popular, we started the firm Online Industry with a lot of email modules, study materials, assignments, and all that through online. So we called it Online Industry, but the classes were all offline. 10 people, 15 people, 20 people come together in our center. Started with Alua, and now we have more than 10 centers. More than 20,000 people in our platform, because last 1.5 years before, when the pandemic started, we really became online, and then we started this webinars. Myself, Dr. Binu Abraham, practicing in Kochi for the last 22 years. And my close friend, my consultant pediatric dentist in my clinic, Dr. Joby Peter. Both of us sat together and came out with this concept called as Online Industry way back in 2008. Started in our small center in Alua and then spread across to 10 centers in India at this point of time, all offline centers in these places. 20 people register in Delhi, we go to Delhi and conduct class in Delhi. Ahmedabad, Pune, Bangalore, Chennai. So for all these places, we have centers. But presently, we have suspended all the offline programs due to the pandemic. We are planning to resume it as soon as things get better in the COVID perspective. Let's hope and pray that we get out of this pandemic at the earliest and start our offline programs at the earliest. Presently, we are doing webinars. We have free 1-hour webinars and paid webinars, which is like 3 to 7 hours. Maybe even we had a 3-day paid webinar couple of weeks before. Huge hit. People from almost 32 countries attended. 3-day webinar. What you are listening to tonight is a 1-hour webinar, free 1-hour webinar. All our webinars can fetch you a certificate of participation. So do not miss any chance. Today's is from Exam Alert. This is a wing of online industry exclusively as a helping hand to final years. That too during this pandemic time, they lost their real class stuff due to the pandemic in multiple colleges. So we decided to give a helping hand. Cover 10 short notes, some long essays, short essays. That way they can, it's a visual treat. You can see a lot of stuff happening through the slides of the faculties. That way you will remember that, you will recollect that during your exam. That was the purpose. We have a lot of free 1-hour webinars coming up, all about local anesthesia coming up, orthopedic movements. All a dentist should know about orthognathic surgery is in the pipeline. That's also coming by Dr. Sharif Peter, one of the finest orthognathic surgeons in South India. So he's also coming. We have a program this Sunday. Just 2 more days. Registrations are closed. Thank you so much for the overwhelming support. Registrations are sealed, and we already started with the study materials, articles, printouts to be taken, things to be kept ready for the class. It's a 1-day virtual hands-on on clear alignments. Another big announcement is our tie-up with Lincoln University. Faculty of Dentistry, Lincoln University, Malaysia. Thank the Dean Pushparajan sir for trusting online dentistry and giving us a chance. And this collaboration is going to definitely help we dentists. We are coming up with the first program next Sunday, not tomorrow, day after tomorrow, the Sunday after that, not this Sunday, July 18th. 1 full day program on preventive and interceptive orthodontics. You attend this program, you will never ever tell patients or parents, come back after the age of 13 years, we'll do orthodontics at that time. You will see, identify a malocclusion at a young age, and you will do whatever possible to stop it and improve it. 1 full day on various aspects to look into the pediatric malocclusion. And moreover, this is a chance to get 1 international certificate in your CV. That international certificates can be very, very useful. If you're a private practitioner, for your reception area, student for your portfolio. So it's only going to help getting an international certificate sitting at the comforts of your house. Getting an international certificate is not a joke. So think about it. But many listening to me are students, so may not be really interested in this, and this may not be your right time to do it. But any practitioners listening to me, this is going to change the way you look at pediatric malocclusion, and you're going to get an international certificate, which is definitely has a value, huge value. Anyone of you listening to me at this point of time, not a member of online dentistry, please note down these numbers: 98470-32032 or 94463-21220. Please put a personal message saying that you would like to be in online dentistry WhatsApp group. We will add you to one of our WhatsApp groups so that you will not miss any coming up programs. Just wanted to tell you that we are almost getting nominated to Limca Book of World Records for the maximum number of webinars conducted in the free webinars conducted in the pandemic period. Thank you so much for the support of each and every one listening to me. You refer to your friends, their friends refer to their friends, and that is how we have more than 20,000 people in our platform and could conduct all these webinars. Now, coming to today's program. Exam Alert, final session when it comes to short note preparations and short essay preparations for final years. 2 full rounds of free webinars conducted on all final year subjects, slowly planning to move into third year, second year, and first year, and also planning to have clinical classes, mock vivas, all that discussions and plannings, preparations going on. So you are now listening to the concluding session of the first round of clinical alert, exam alert, first round of exam alert. And today is the concluding session. And concluding session has to be done by none other than Dr. Joby Peter. My friend, my consultant pediatric dentist, great speaker, international speaker, author, has authored books, multiple articles, national and international. A personality to meet. When you get a chance to come to offline programs, you should see the energy. So with these words, Dr. Joby, without much delay, I've handed it over to you because you have a big job to do today. I can see the list of topics you're covering today. I know how tough that is. Guys, just listen to him. It will be benefited, if not in the exam, in the Viva at least. I bet you will remember Dr. Joby and the class he took today. That's it. Over to you, Dr. Joby.
Thank you. Thank you so much, Dr. Binu. Good evening, all. Good evening. And thanks for coming again in a huge number in Zoom. And we have some numbers in YouTube also, because already the topic of subject of examination is over. Periodontics, even it's over. All the 2006 scheme in Kerala University of Health Science I'm talking about, and 2010 scheme, both the exams are over. But I'm surprised to see the questions that was asked today. I think we are going to discuss around 2 to 3 questions that is already asked, and many of other questions that we have covered in the psychoanalytical theory, psychosexual theory, all those things which have been asked. I was so happy to see the question paper. So I asked my own students in Anu Dental College where I'm working, and they said they have done it well. Let's hope for the best. They have done it well. And today's question, since the questions have been answered already or asked already, you have answered already. So what is the point, Dr. Joby, in attending this? What is going to help me? You know, all the examiners who comes to you to take Viva for you, definitely they give priority. How have you given the theory paper? They will ask you, how was your theory paper? Did you do well? Did you write this question? So many times they do that. So by attending this 6 more short notes, which is being prepared in a way that it can be given as a short essay, that's how it is being prepared. So definitely you will get a lot of Viva questions. When they ask, you will be able to tell the definitions or the classifications or the catch or some trick they have asked you to, they might ask you in your Viva will be covered there. So welcome to all of you to the Anu Dental College, where I'm working there, to my Department of Periodontics and Preventive Dentistry. Please do visit at any time. I just want to start with a small story. A group of frogs were sitting on a wooden log near a pond. They were discussing, chatting, and they were all in a corona time, nothing to do, full lockdown everywhere, nowhere to go. So they were all sitting around the pond and discussing things and all. Suddenly, one of this frog stood up. He stood up and said, I am going to climb the top of the tree. They don't have any duty, they were doing it. So one frog stood up and said, I'm going to climb the top of the tree. Others laughed at him, said, you can't do it. What are you doing? You're nonsense. You cannot do it like that. But this frog did not stop. He went, he started climbing. So his friends gathered around him and started laughing at him and telling him, what funny thing you're doing again. Actually, this frog was a deaf frog. So he did not listen what his friends said. He was a deaf frog. So All the friends surrounding him was criticizing him, telling him funny, making fun of him. But since he was deaf, he was not bothered. He did not know. He thought everybody is raising hand so that he's encouraging. So he started climbing. He started climbing, climbing, and finally he reached top of the tree. The question, the moral of this is be deaf to negativism in your life, doubts in your life, tension in your life. You have to be deaf into that. Whichever situation you are today, I do not know, but let me tell you, if you are a student, there will be negative thoughts in your life. Is the exam is going to be good, bad? Is the practical, will I crack or not? Or the tough questions they are going to ask or not? There will be a negative question. If you are a person who's preparing for exam, like NEET or any exam you are preparing, there will be a negative thought always. Oh my God, if they ask this question from this, that question from that, if they ask this, so confused you will be. If you are a person who's pursuing your life outside India, oh my God, what going to happen? Will I be able to successful? If you're a practitioner, you will be thinking tomorrow, will I get this much number of patients? Will I get that? Will I get this? Will I be able to do that? So much negative thoughts always comes in your mind, and that is the one that pushes you down. So deaf to these negative thoughts, then you will reach heights. So that is one thing I just wanted. The deaf frog story tells you be deaf to negative thoughts in life. If you want to reach heights in your life, positive, be deaf. Better to do that. So today's first question to be discussed is a stoic child. And I'm so happy to see that this question of stoic child is being asked in 2000. Sorry for that. Yes, it is asked in 2016 scheme in Kerala University of Health Science. That is the 413th, 11th question is stoic child, stoic behavior. Anyway, I'm going to evaluate this question because we have to go to the university to evaluate this. So they have not called for the evaluation within next week onwards. The evaluation will start. So I'm going to see how in Kerala University, which you are attending, you are evaluated in other outside university. I don't know, but I'm going to evaluate that. So let me see what you have written there. But if in case your university exams are not over, listen to this. Or if you have already written that, and if in your Viva somebody is going to ask you stoic behavior, what did you write? This is the answer for you. Listen to this word by word. This is the answer that you should have written, or if next time comes, you should write if the exams are not over. So this entirely stoic child is related to the classification of behavior given by various authors are there. So many authors are there. And one person he's the only guy who classified this. So those people who like this guy will definitely ask this question because he is considered as one of the pioneer in child psychology. So this guy called Wright, and there's a textbook called Wright. If you are a postgraduate and if you want to learn more about behavior management in pediatric dentistry, or in that case, even for adult, one book you should read is Wright's behavior management book. So in this book, or in him, he classified a stoic behavior as a child with no facial expression and abstain from communication. He's shy. He always keeps behind somebody, and he is very have no expression on his face. He just expressionless face he will show. That is that character he classified that. It is usually, the studies said, it is usually seen in children with physically abused children, like a mother or a father who's aggressive, beats the child, shouts at the child, pushes the child. Physical abuse in the house is happening. Those children will be having a lot of negative thing in their mind, scare thing in their mind. They are scared of everything. They are scared about talking to friends. They are scared about talking or mingling with the relatives. They are scared about communicating with others. They are scared about, they have only one hope is some person like a mother is the protective thing. Only hope is that person, and they will all subdued under that person, because the somebody in the home is very authoritative, possessive, or aggressive it is. So the child behaves like that. So usually it is seen in a physically abused children. The psychological problem range from chronic low self-esteem. That means he is always suppressed. Suppressed. He is not expressing his talent, his idea, his dream, his vision. Everything is suppressed. Somebody else is dominating. So he would not, you can't judge how he will react in a situation. Very dissociative kind of states he is in. He don't have it. So always he will go into a low self-esteem, submissive, protected under somebody, like that kind of nature he will go. The cognitive effect range from attentional problem that he may not listen to you. He will be shaking. Yes, 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 yes. Then you ask him, can you do that? He will look like this. That means he is not attentive because he has got a fear. He is thinking about what is happening. Somebody sees that person who's very aggressive, who's very this standing next to him. Like it can be a father, it can be a mother who's standing next to him. So his inside mind is towards that person's attention, to gather that person's attention. So that person might have told, you have to behave well, otherwise I'm going to beat you. So he will be preoccupied. Okay, I have to behave well, nice. So he will shake hand, he will sit quietly, he will do whatever you say, but he's not listening to you because he want to impress the next person standing to you. So the cognitive behavior change from attention problem to a learning disorders to severe organic brain disorders in these children. And poor peer, I already told you, no peer relations. Because of this, they are very submissive, scared to interact with them because of the dominant uh, character that's happening to them. So what are the characteristics of this behavior? The characteristics of this behavior is this patient in the dental chair will accept the treatment because the father or mother is standing. They might be holding, they will be standing opposite to them. So they will show expressions, and also he knows the feel. The child will accept the treatment. But inside, child is tensed, very tensed, but he'll cooperate. Whining and timid, sometimes they do that, but when the authoritative nature comes, they will listen to it. Milder but little anxious, may shield behind the parent, may whimper but does not cry hysterically. Seldom tears will come out because they are so scared. You can see expressionless feature. They open their mouth, you give LA, you start feeling and drilling. They don't say, you might, oh, such a nice guy. But after a time, you can see tears dripping down from their ears because they're scared. They're inside their mind, they are drastically scared about it. So, what is the dental significance of this kind of behavior for us? They cooperate and accept all treatment passively with any complaint or facial expression. They do not communicate with the dentist. You cannot have established a communication with them. They might shake their head or don't do. You ask them to open the mouth. They do everything what you said they do. For you, you think, okay, such a nice cooperative child it is. But it's very difficult to express a communication with them. Be very compassionate. When you see like this as a dentist, you should be very compassionate with them during your treatment. Do not try to hurt them more. Already understand that they are under tension, pressure. So you have to be very compassionate. You should feel out of your heart for this kind of illness. And you should doubt for physical abuse in that. That is the plan. That is the most important part for a stoic behavior child. You should always put a question mark. Is the child is physically abused or not? And all stoic child are not physically abused. Let me tell you that also. But that should be a question mark. You can. There are methods to and find out whether they are physically abused or not. So I'm not going into that, but you should have a question mark onto this. If there is an issue, it is the duty of the dentist to report it, but not in front of the parent and the child. So this all should come in your questions about stoic behavior child. Conclusion is that dentist should keep an eye on the child neglect and abuse while examination during treatment. That means a stoic behavior child can undergo physical abuse. So what is the role of a dentist? We should understand that stoic behavior doesn't mean that the child is very cooperative. I will do all the treatment and finish it off. No, that's not the way it should be. You have to understand that 90% of the 80 to 90% average, this child can undergo child abuse and neglect. So you should report if it is required. So this is the complete answer for stoic behavior or stoic child if they ask you. So everything is better. If you answer this, you will get 5 marks, 7 marks. Of even if they ask you in Viva, tell these things in a stoic behavior child. I already told you the behavior nature. I told you what happens there and the dental significance will tell. Your Viva will be best for that. Okay. So I have a quiz for you. I have a quiz for you. All of you, please come to the chat box. There is a quiz for you to answer. So what does the quiz come? I hope you can come to the answer at the chat box. Which among the following advice, please read this question very carefully. Which among the following advice is true for a high caries risk patient who had a heavy dinner with dal, chapati, chicken, salad, and soft drinks, and gulab jamun and ice cream? Oh my God, that was a heavy dinner. I mean, before Corona, our weddings should be have all these things. You can go and take it. Our conferences are all like this. So a person who's having a high caries risk has taken a heavy dinner, which includes all those things. So what advice will you give to this patient if he's sitting in front of you? What advice will you give? Option A, you can skip brushing. Don't brush on the day because you already done in the morning. Brush your teeth and with toothpaste immediately after the meal. Brush your teeth without toothpaste immediately after the meal. Brush your teeth without toothpaste 10 minutes after the meal. Brush your teeth with toothpaste 60 minutes after the meal. Which will be your option? Can I see this one? Can I see the chat box? Can I see the chat box? Which will be your option? Okay. Great, great. Many, so many answers, correct answers you have done good. That's great. The correct answer, still answers are coming up. That's great. That's great. You're not sleeping. The right answer for this, is E. Brush your teeth with toothpaste 60 minutes after the meal. Now, what would have been the reason for you to tell to wait for 1 hour before brushing? Can you put that in your chat box? What would have been the reason for you to tell to wait for 16 minutes after that meal? Yeah, PH, yes. Great. I think there are so many postgraduates or anybody who has attended some of lectures are there. That is good. Whatever you said is right. The key is critical pH. The critical pH is the key because if you see here, you can see patient has high carbohydrate. Okay, not only the critical pH, high carbohydrate diet the patient has taken. Second thing is, as you said, the soft drinks, which consist of again pH is dropped, acidic pH it is. So combined with high carbohydrate and the acidic pH, and patient is at a high risk, that means high risk patient definitely will have white spot lesions or high chance of getting caries. So already the pH in this patient is already down, and the body might be trying to make it more remineralizable, come back to neutral, but the patient is not allowing it because his diet pattern is such a way that he cannot control his diet. Now, he had a heavy carbohydrate diet. At the same time, he had soft drinks also and is high risk. If you tell him to brush immediately, what happens is already his high risk white spot lesions are there, then and there. This diet, all the sites are there. Plus your brush, which is very abrasive, and you ask him to brush thoroughly, brush it. What will happen to this white spot lesion? Already the enamel is brittle, acidic environment is already there. So demineralization is happening here. No remineralization potential happening there. And you put the brush and try to brush it. You might induce a non-cavitator to become cavitation or promote more amount of abrasion from the toothbrush can happen there. So that is why you should tell them to wait for 60 minutes. What is the 60 minutes will do? That will slowly flush out the carbohydrate, flush out the pH, the acid drinks and everything, and the saliva gets saturated slowly with the calcium, with the phosphate, so that the remineralization process starts and settles down, and then you tell it will be better rather than immediately you tell them to do that. So that is the role of critical pH. Now, next question is short note, which is usually asked in Viva or this is critical pH. So when it asks, you have to write the introduction. So you have to write in the introduction that dental caries is a multifunctional disease, multifactorial disease, and saliva plays an important role. That is very important. This critical pH determines to saliva. So you have to write saliva is an important role. Enamel is highly mineralized and is susceptible to acid. One line is very important. Next, salivary pH plays an important role in caries development. If three lines, if you write, now, if I am answering, if I'm observing, I do not go next. I will tell that this person knows the stuff because pH of saliva, the most important significant factor. Normal favorable pH for tooth enamel is 6.57 neutral pH, ideal for the enamel, safe and sound for enamel. So with that introduction, I know that, oh, this person knows very good, very well. Next could be the definition, critical pH definition. What are the definition? Critical pH is a pH at which the saliva no longer remains saturated with calcium and phosphate, thereby permitting the hydroxyapatite of dental enamel to dissolve. If you tell this, that's the ultimate definition you can tell them. The saliva is no more super saturated or saturated with the calcium and phosphate. They are deprived of that. And they cannot remineralize the enamel, which has been hydroxyapatite, which has been demineralized. So this is the pH where saliva doesn't have protective factors for dental caries. All negative factors which cause remineralization is present there beyond this pH. If it is under this pH, it causes caries. If it is above this pH, fine, safe. That is the line mark you need to know. So, and that pH is 5.5. Anything 5.4, bad to the enamel. 5.6, 5.7, good for the enamel. That's it. So if the pH of the solution is above the critical pH, that like 6.5 and all, then the solution is super saturated with the mineral and more mineral will be there to precipitate out. So the enamel will get strengthened. Other way around, if the solution is less than the critical pH, like 4.5 and all, if it go, it will be undersaturated and there will be no protective factors for the enamel. That is the important thing. So if you write this, it will be the best definition that you can give. And if you can draw this diagram, demineralization and remineralization diagram, a simplest diagram you can, if you draw, whenever the pH, the critical pH is 5.5, and anything beyond that 4.5 towards the acidic, it becomes this cause demineralization. Anything above that, it causes remineralization. Like the calcium phosphate will get deposited. Here, calcium phosphate, that's a negative mark I give because all will be dissolved. Dissolution, of course, there. Loose minerals there. So one of this diagram, if you draw, they will understand. Okay, fine, you understand this. The next thing that you have to draw, next diagram that you have to draw is Stephen Coast. Represent with the diagrams. You write the definition, write the introduction definition, then go for these diagrams. You'll understand what you're going to do. You don't have to write it is, then was, and all spend time. Do a diagram and finish it off. Calcium phosphate, negative, mark it positive, green, negative is red mark. We'll know, okay, fine, you understood it. Then this diagram should be there. Stephen Curves 1994. That is an important diagram where patient at neutral pH takes a sugar. The moment the patient takes the sugar, pH of the plaque comes down drastically, and 5.5 is the critical pH. It goes beyond the 5.5, and it takes some time to regain it. You can see. So where any time it is under 5.5, there is demineralization. Calcium phosphate is lost. But the moment it goes above 5.5, remineralization occurs. And how much time it takes? 30 minutes minimum it takes for the saliva to start the remineralization process. So if you have a chocolate now, see, if I'm having any juice now, imagine if I'm having a juice. See, I'm a sip the juice now. I sip the juice now, which is sugarated. The moment I sipped it, from that moment, the pH of the plaque will come down into the critical, below the critical pH. Then it will take another 30 minutes minimum for my saliva to come back to the normal, that is above the critical pH and towards the remineralization protocol. So till that time, I should not be having any snack or anything minimum. So that is why that graph is very important. 30 minutes to 1 hour is very, very important to that. You have to draw this graph. The clinical application of critical pH is the next thing that you need to answer. So what you can write in clinical application, diagrammatic representation is the best. It is not possible for you. You are not a chemist. We are dentist. We are treating with the patients. So I cannot write the chemical formula of hydroxyapatite. And even the examiner also is a dentist, not a chemist. So do not try to write the chemical formula, demineralization, that is gone. This one. Simple thing I tell you is draw a diagram of Stephen curve like this. Neutral pH 7. That is good. Safe zone, this one. Critical pH is 5.5. And anything below that is a danger zone. First diagram you in clinical application, just draw this diagram first. That is the Stephen curves and the daily diet, 6 p.m., 6 a.m., 7 a.m. child, the midday, just like that. So we can understand, okay, you have drawn a diagram saying that 6 p.m., 7, 8, 8 a.m., okay, the food intake, hourly, you have written that, and you indicated a pH on one side. So the vertical graph says that, okay, this axis says that, okay, fine, I understood. So this is the normal one. Then now write that patient is taking a diet or food intake. Just like, you don't have to draw this picture. Just that the patient is taking a food at whatever time. A healthy Stephen curve or a less healthy Stephen curve. We can see a less healthy Stephen curve, less healthy. We can see that in this diagram, you can see that majority of the time, the pH goes below the critical pH, or majority of the time, it is the danger zone. So you can put the outcome saying that more demineralization is happening here and less opportunity for remineralization is happening here. So a less healthy Stephen curve, one diagram will tell you, okay, fine. That means more amount of demineralization. You can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 times it is below 4 or almost in the 4. That means demineralization is happening here. No chance to this one compared to above side is 1, 2, 3, 4, 5, and 6, only 6, and more than that, demineralization. So less healthy Stephen curve, we can see that. And then healthy Stephen curve. What do you mean by healthy Stephen curve? You see patient is taking food multiple times, but what happens? There's a time gap is so, the gap is so much the saliva can roll back. And you can see only 5 times it goes below, but majority of the time is there's a huge gap. You can see 8 p.m. to 10 p.m., 2 hour gap, 11 p.m. to 1, again 2 hour gap, 1:30 to 4 p.m., too much gap. 4 p.m. to 7 p.m., too much gap. And after that. So you can imagine the patient, even though have taken more snacking, but there is a gap. The gap is the duration is given so that the saliva can roll back. If you see here, frequent, there's less time the patient have done it. Their coffee, everything has gone down. Duration is very less, and most of the time you can see the patient is exposed to sugar-rated drink here. But here the gap between snacking is increased there. That is a duration which I told you. That is why I told 60 minutes is minimum required for the saliva to come back to normal. So if you put this picture, Stephen Curve, then you can directly go for the conclusion. The conclusion says that critical pH is the benchmark for enamel demineralization and remineralization. All positive factors like frequent snacking, sticky foods, which with improper hygiene can increase the risk of dental caries. All measures to bring the salivary pH above the critical pH 5.5 should be adopted to prevent dental caries there. So this concludes your critical pH. So many of you have written, I've seen, I'm into this for 20 years, but I have not seen a good Stephen curve or less potential Stephen curve or a bad Stephen curve, normal Stephen curve. This kind of separation I have not seen in any of the diagrams. If you represent yourself with this, you will get more marks onto that. Now, quiz for you. The next quiz for you is a patient of 7 years of age has come to you. What is the best space maintainer appropriate for this child who has lost 7.5? The 7.5 is extracted. Child needs 7 years of age. What would be the best space maintainer? Is it A, B, C, D, or E? I just want to see the answer. Let me see the answer. Okay. 7.5. Oh, somebody has asked the question. 7.5. That means E. 7.5 is E is lost. What would be the best space maintainer for this patient? I will wait. Some excellent, excellent. So many answers they have put. So much, so much. So good, good. So many answers. Okay, done. And the right answer is given by Dr. Srija Jose. If I'm not wrong, Dr. Srija Jose Matthew, Dr. Srija Rose Matthew, you have done the right answer. The right answer is E. Please, this is what mistakes us. This is the trickiness of the question. 7 years means 6 will be erupted. 5.5 to 6, 7, definitely it will be erupted into the oral cavity. Now, 7.5 is second primary molar. That is gone, or you extracted. So why you want to give distal shoe here? Did they said that at the age of 7 years, 6 was not erupted under something like, did they mention? No, no. Very frank question. Follow the sequence of eruption. In the sequence of eruption, 6 by 7 years, it has to erupt, right? It will be erupted. And that is why you got misled there. It's a correct answer is a band and loop. First, you give a band and loop that is being removed, band and loop, because there is no lateral incisors erupted there, so you can give a band and look. And but you have to inform the patient saying that after 1.5 years, while the lateral is erupting during the process, you might have to change into a lingual arch. But 7 years, usually 6 will be erupted. That is the catch in this question there. So Dr. Ross Matthew, thank you for that meticulous looking into the question and answering. Next, again, listen to this. Please listen to me very carefully. 8-year-old patient is coming with severe pain in her tooth. And you examine and you can see a dental caries there. There's a dental caries in that 8 to 8.5-year-old, saying that there is caries is there. So what will be your treatment option for this? Can you put what will be your next protocol? You tell me. Just tell me the next protocol. Patient says that pain when the patient is having food in this. Patient age is 8 years of age. And this is the real clinical picture. What will you do for this patient when they say pain while having food and patient age is 8 years of? What will you do that? Tell me the next diagnostic protocols you like to do. That's all. Can you put in the chat box? Next diagnostic protocol. Just tell me next, what will you do when you see tomorrow in your clinic, in your department, a patient is coming like this, saying that 8 years of age, and what will you do? Okay. Deepak Raj, Dr. Sinha, and yes, radiograph. Everybody's a radiograph. Yes. So definitely I'll go for radiograph. So pain, whenever the patient says, important diagnostic tool is radiograph. You have to take a radiograph. So I took a radiograph. So the same patient radiograph is there. So in radiograph, what we are supposed to see in an 8-year-old. Okay. See, this is important things for you. What you are supposed to see in an 8-year-old, X-ray and check whether apex formation is completed or not. Ammu, Sugandhan, great. Pavitra, great. Great. That's exactly we are supposed to see. The radiograph is not to see the extent of the caries lesion. At the 8 years, the first and the foremost thing is to see the apex is closed or not. Most important thing. So exactly that I seen. So whenever in your clinical practice you see 8-year-old is called a young permanent tooth, that means the tooth apex is not closed, because the apex of this kind of tooth is under the process of development. The root completion take place 3 years after the eruption of the permanent tooth. That means if it is developed on 6, I told you by around 6 it erupts, 6.5 it erupted, or 7 it is erupted. So it will take another 3 more years, that is 8, 9, 10 minimum for the roots to be completed. So 8 years definitely means the roots are not completed. So incomplete root development. Apex are opened, but the advantage on the side with the open apex is rich and abundant blood supply, immature nerve development, repair capacity so much, and you have 2 options. Depending upon the clinical situation, you have 2 options. Not depending upon the root development, depending upon the clinical situations, the patient in front of you, you have 2 options like apexogenesis or apexification. So this should be your introduction into a question called apexogenesis and apexification. And the types of immature tooth can be a vital immature tooth. The tooth is very vital. It is surviving vital or non-vital immature tooth you can have. Luckily, you saw it at the age of 8 years, so it can be a vital one. But the same situation can be a non-vital if the same parents ignored this, continued, and 11, 12 years the patient comes and you take an IOP. The moment I told you is a permanent teeth, IOP is required. You can see that roots are not formed completely, but completely dead. That non-vital immature tooth you can have. So vital immature tooth with pulp is already exposed or there are no pulpal exposure. Same way, non-vital immature teeth can be with pulpal exposure and without pulpal exposure. So when this four situation with an immature tooth with two option comes to you, what are the teeth and options? Vital, immature tooth with pulpal exposure or without pulpal exposure, you have procedure called apexogenesis, which comes under direct pulp capping, indirect pulp capping, and pulpotomy. What about non-vital immature tooth with pulp exposure or without pulp exposure? You have two options, apexification or revascularization. So you can also put like this, when a young tooth, young permanent tooth. So I have seen many times people write RCT, do RCT also. Please, it is not required at the first period there. So young vital tooth, you have an option called apexogenesis, which can be done by IPC, EPC, that's indirect pulp capping, direct pulp capping, and pulpotomy. If it is young permanent tooth which is non-vital, apexification or revascularization. If you can write that, it will be better. So a question for apexogenesis and apexification is been asked as a short essay. It is asked a short essay. So how will you write this? You should have an introduction. You should have a treatment modalities of pulpal pathology, apexogenesis with the definition, rationale, goals, indication, contraindication, procedure, and medicaments used and a conclusion. And apexification again should have a definition, objectives, indication, contraindication, procedure, medicaments, difference between apexification, apexogenesis, and a conclusion. So it can be asked as a short note like apexogenesis or apexification, or it can be asked a short essay, apexogenesis versus apexification. And I think this was asked in 2010 scheme in Kerala University of Health Science as short essay, apexification versus apexogenesis. If you see my first slide of exam alert, I already included this exactly the same thing in our exam alert, and it has been asked here that we could not cover on that first session of first on me, but I'm covering it here. So it's all important clinical experience we are going to share in this platform. So how will you approach this? You may or may have written it, but if you have not written the way that I'm going to explain you, do not worry. Do not worry. There is something called your Viva is going to come. Answer that, attempt that. So how will you do this definition? What do you mean by this open apex or incomplete rhizogenesis? If an undergraduate write about a rhizogenesis, a word called rhizogenesis, we will salute you. What it refers to the absence of sufficient root development to provide a conical taper to the root the canal and is referred as a blunderbuss canal. This means that the canal is wider towards the apex rather than the cervix. This is Franklin S. Wine's definition of incomplete open apex for that. The rationale for this is to maintain the integrity of the radicular pulp tissue to allow continued root formation. Root end development occurs as a tooth with a normal pulp with a minimal inflammation. Poor long-term prognosis of an endodontically treated immature teeth can be avoided because you are maintaining the vitality of the teeth. So that is the advantage of this. Relatively thin dentine at the apex, you cannot obturate the canals because it gets prone to fracture. So by doing this apexogenesis, what are you doing is you are creating a normal dentine at the root with the thickness so that it goes down and normal root closure occurs, natural thing occurs. So that root is more resistant to fracture rather than an endodontically treated tooth which is liable for fracture, even root fracture there. So when you ask apexogenesis to apexification, how will you compare? Apexogenesis is a vital pulp therapy procedure performed to encourage continued physiological development and formation of the root end. This is the classical definition for apexogenesis. Now, what about apexification? it is defined as a method to induce a calcific barrier. Here it is continued normal physiological development is apexogenesis, but here it is inducing tooth to form a calcific barrier. That is the classical difference between apexogenesis and apexification. One is normal physiological, other one is inducing to get an apex closure. What are the goals of apexogenesis? Sustaining a viable Hertwig's epithelial root sheath to allow continued root development so that crown root ratio is maintained according to the normal picture. Maintain the pulp vitality in the root at least for the maturation of the root. Promoting root end closure physiologically, normal or naturally. Generating a dentinal bridge at the site of pulpotomy, which is natural. That means a tooth has been injured. You remove the infected part and kept a material, and that material form a natural calcific barrier so that further ingress of bacteria doesn't occur. That is like a dentine that is natural, enamel is natural. So what have you done by keeping a material inside the pulpotomized pulp is you promoted that pulp to form a natural dentine like our normal natural dentine that prevents any ingress of bacteria further from that point. Anything above, I don't know. So that is called apexogenesis there. What about apexification? Only one goal, to induce either closure of the open apex, whichever part it is, by stimulating whichever remaining Hertwig's root epithelial sheath is there, it induces the to form a closure, which is not natural, like an artificial bridge. It has been formed because you kept a material which induces this soft tissue. So one is natural closure of the root, other one is inducing a bridge to form, get a artificial closure there. That is the difference between these two. Now, indication, apexogenesis indicated for traumatized tooth, a tooth which underwent trauma within 72 hours, or pulpily involved vital permanently. That means accidentally exposed, which was a deep caries lesion. You want to remove all the soft dentist, but it is got exposed. But the roots are not completely formed there, like this kind of fracture trauma or the one. There is no history of spontaneous pain or percussion, sensitivity to percussion, no pain like that, and no continuous hemorrhage or no hemorrhage. That means if there is no hemorrhage, it's a dead part. Or hemorrhage cannot be controlled means it's a chronically inflamed part. Normal radiographic, no pathogenesis, no nothing is there. In conditions like traumatic luxation, because the tooth is mobile, it is better to go for apexogenesis in those kind of things. Otherwise, the tooth will go for non-vitality. So traumatic luxation, apexogenesis is indicated. What about apexification indication? It is indicated for a young, immature, non-vital permanent tooth with open apex, like this, non-vital. There can be abscess, there can be drainage, there can be swelling, irreversible pulpitis. All those features were irreversible pulpitis, but in an open apex condition, you can use that. That means night pain, lying down pain, continuous pain, throbbing pain, radiating pain, pain without any kind of stimuli, full night pain, pain under medication. All those features which are irreversible pulpitis are indicated for an apexification procedure. History of trauma after 72, like 1 week back, 3 months back, or 6 months back, 2 year back, 3 year back, immature teeth, if it is present, then apexification would be the ideal choice for that, like this too. Contraindications, evidence that radicular pulp has undergone degenerative changes. Apexogen contraindication, you cannot give apexification when there is radicular pulp has undergone regenerative changes. Tooth with unfavorable horizontal root fracture. Horizontal root fracture that is very close to the margin. It cannot survive because it's very difficult to get an isolation or a closure. It is very difficult. Like drainage, which I have told you, all these things all discussed there in the indication for whatever indication for apexification would be a contraindication for apexogenesis. So very simple. Whatever indication we discussed for apexification would be a contraindication for apexogenesis. So that's very simple. Whatever I said for contraindication or indication for apexification would be a contraindication here. What about the contraindication for apexification? You can do very short root. Root length is very small. Vital pulp is there. Please don't do that. Compromise periodontia is compromised. So there are options for a very short root which is non-vital. There are options which we'll discuss later time. And method of apexogenesis is the IPC, DPC, and pulpotomy. And method for apexification is placing a medicament directly onto the canal, sterile canal, and let that material forms the barrier. And beyond that material, let the calcific bridge or whatever forms according to the material that you kept, let it form so that the tooth can be maintained in the arch, but a non-vital teeth. So whether it is apexogenesis or apexification, the material of choice is calcium hydroxide. So this calcium hydroxide can be asked as a short note. What is calcium hydroxide? So you have to write about the composition, who invented, indication, and this too will come that also. MTA, mineral trioxide, can be used. Biodendine can be used. So these are the materials which can be used for apexogenesis and apexification. Next, if they ask you about, next is the long short essay, you have to write about the procedure for apexogenesis. So what are the procedure for apexogenesis? One by one is give an local anesthesia and isolate with a rubber dam. Remove all caries tooth structure and open up the pulp chamber, whichever remaining there. Remove the coronal pulp with excavators. Care is taken to prevent damage to the radicular pulp, because you know only the coronal pulp is removed. If it is an indirect pulp capping, you remove all the soft caries lesion and then you seal it with the indirect pulp capping lesion there. Then you can rinse. If it is a pulpotomy kind of procedure, you rinse the chamber or the cavity that you prepared with the sodium hypochlorite or a saline to remove the residual debris, soft caries, dendine, or whatever it is, remove that and place a moist cotton pellet over the amputated pulp, or if any kind of, because to arrest the bleeding from the side. Now, whichever cavity that is prepared, like an IPC where the pulp is not open, very close, you clean all the things with the rubber dam and everything is done. What you do, you have to keep a material. It can be calcium hydroxide, MTA, or biodendine mixture. If it is a pulpotomy, you remove all the coronal pulp and then kept, clean it nicely, and then keep the material directly on top of the amputated coronal pulp. The coronal pulp which has been amputated, remove the radicular pulp, what is remaining, you keep the material there, followed by temporary restorations. Follow-up with radiograph is taken periodically to check for the root development. So you need a, now from here onwards, what you require is a follow-up for apexogenesis procedure. What about apexification? Once the root is completely developed, you can go for obturation or whatever thing that if you want, you can go for that. That is for the apexogenesis procedure. What about apexification procedure? Same LA, anesthetize the tooth with the rubber dam, isolation, everything has to be done. Straight line access onto the canal orifices or whatever it is done. Irrigate the pulp, tissue remnants, and irrigate, and with the sodium hypochlorite, whatever it is, you have to find out the working length here. In apexogenesis, you do not need working length because you are not going into the root. Here, you need to find out the length of the root. So you need a working length here. Once you've done that, you remove all the things, working length is established, you keep a material like a calcium hydroxide, anything, apexification procedure, material can be kept there. Once it is kept effectively, seal the procedure, seal the thing, and ask the patient periodically every 3 months to monitor if the tooth is symptomatic or not. You have to check it. If it is symptomatic, you might have to re-enter. Otherwise, you have to keep the material there and keep on monitoring there. Patients again recalled and examined for radiographic evidence for root formation or that continued closure of the apex. You have to be maintained there. Then confirm the progress of apexification by passing instrument through the calcium hydroxide. You have to find out whether you have get a stop there. If apexification is successful, when you remove the calcium hydroxide, you pass the material, you get a stop there. That means the calcific bridge is formed there. You till you get a complete classification process, you have to continue to do that. So treatment time for apexification could be 6 weeks to 18 months to 2 years it might take. Once you get a proper stop, then you go for final obturation is done. and the entire thing is closed with that. So the material, now the latest thing for apexification is this is the calcium hydroxide one. With MT and biodendine, you can add a knot onto that. You don't need multiple appointments. You clean, remove, everything is done. And the same visit, you just put MTA onto that root and apex after the work film that is taken. And that will act as a calcific barrier because it's a hard set cementing. And on top of that, you can directly go for obturation there. So that is the procedure for apexification. So you can see the difference in the number of steps for the apexification and apexogenesis. It is very simple. Remove and keep the material and give the coronal fill. You can see continue root development. But follow up for both till the roots get either completely formed if in apexification procedure, apexogenesis procedure, in apexification, complete calcific barrier is formed and tooth is asymptomatic, no preoperative, postoperative pain. You have to follow with that. So calcific bridge should be formed, continued apical root development should be there, absence of any internal resorption or external resorption should be there. So you need to take radiograph every 3 months to see whether the calcific bridge or the root development is normally happening or not, and any signs of internal or external resorption is taking place or not. So that is why the follow-up both require a radiograph, and this amount visit has to be done till the patient feels asymptomatic for a particular period of 2 to 3 years. Then you can call it that the tooth is become successful in that. So apexogenesis is you promote the root to form normally. Apexipation is like you induce a calcific bridge by keeping a material, or you keep a material which act as a calcific bridge at the apex. So you are forming the apex by yourself, and that material will help to do that. That is called apexogenesis and apexification. So if you have not answered like this, do not worry in the short essay which has been answered. But if they ask you what is the difference between apexogenesis and apexification, in your definition, apexogenesis is a normal, natural, physiological development of the root should come, and apexification is inducing the root apex to be formed. If you can put that, that will be the best thing that you can get. So another quiz for you, which one of the following is an ester or local anesthetic? Ester, local anesthetic. Which among the following is an ester, local anesthetics there? Is it bupivacaine, lidocaine, mepivacaine, tetracaine, or prilocaine? Which among the following is an ester, local anesthetic? Can you put in the chat box, please? Which among the one is a ester, local anesthetics? So many answers are coming. So many answers are coming. At 8:38, the first answer that oh, great, Pavitra, Shrija, Trina Mukherjee, Deepika, great, great, great. Thank you for the responding. The correct answer for this is D, tetracaine. Who has answered it? Tetracaine. Who has answered tetracaine? I think the first answer, which the name is 35 Ummit Kulsum, Ummar Kulsum. Sorry, I hope it is like that. And Tina, no, not Tina. Ummar Kulsum is the first person who has answered the right one as tetracaine, because all others are amide. Bupivacaine, lidocaine, mepivacaine, prilocaine are amide, and the ester is tetracaine. And the importance of ester, it can have more allergic reaction compared to amine there. Congratulations. Thank you so much. So next, how many of you have undergone vaccination? I mean, your age group vaccination, if you have received or not, but these are the videos trending as a viral, celebrities getting vaccinated, and they are a little scared about vaccines. Every I mean, injections are always scary things for that. Now, pediatric consideration local anesthesia, which has been asked as a short note, but this is going to be one of the favorite question in your Viva there. So what are the pediatric consideration for local anesthesia? When this question is asked, first you have to write the definition. Local anesthesia is a temporary loss of sensation, including in those part of body procedure by topically applied or injected without depressing the level of consciousness. This definition should be there in the LA consideration. Patient management while administering local anesthetic injection is the next part when you ask this question to be done. Technique of local anesthetic administration is an important consideration in pediatric behavior management. So the thing with the question is been asked in such a way that they want to know what consideration you know while you're giving LA in for a pediatric patient there. So the question goes like this: age appropriate non-threatening terminology should be used. You can't tell them I'm going to inject. You can't show them also. So you have to use age appropriate non-threatening terminology. You have to use TEL-SD or systemic desensitization protocol. You should always use it without the sight of the child underneath or something. You should use that. Topical anesthetic agent should be the first given before the injection. Then pharmacological management like sedations, like conscious sedation, or can be done if the child is free. So these are the methodology should be given for a child, consideration for a child compared to adult that you have to give in pediatric cases there. Always you have to forehand dentistry while administering LA for a child. Very important that you have to follow. You have to stabilize the head of the child properly because you have to hold the hand at the same time. If you are injecting onto the mandible, you have to hold the hand of the child properly so that the stabilization. And you can see why the head, now the entire arm is come around so that the head is stabilized, even if the jerky movement is controlled by holding the hand like that before injecting an LA. If on the same side, if it comes, you should again hold the mandible or whichever area that you are given so that you should hold the hand care. Finger support should be given so that you do not impinge onto the tissue or it goes into some other areas there. Dental assistant should be trained to restrain the child hands, but not firmly. You should not. Should tell the child to restrain the hand, but you should not firm it wholly there. You just gently keep the hand, give the comfort to the child so the child can, okay, somebody is there caring for me, is there or not. Topical application of anesthesia is very important. 20% benzocaine is one thing that you can give. Not used in children with a history of methylglobinemia because benzocaine can cause that. So you should be very careful. You should not be used in children with megaloglobinemia because it can cause these children who are very young age children or under 2 years of age. You never use topical anesthesia with 20% benzocaine. Now, 5% EMLA, that is effective mixture of local anesthesia containing lidocaine and prilocaine, is a very good solution that you can use, a cream that you can use because of the faster penetration, longer acting. If you use this before applying your injections, patients may not know about the pain. So 5% EMLA cream are available. You can use that. And you need to wait for 3 to 5 minutes of topical application before giving anesthesia for a pediatric cases. And needle and length of the needle, you should always check for the needle length. A short, that means 20, to long, 32 needle can be used. Size or gauze of the needle, inner diameter is the what that determine the gauze of the needle or size of the needle. That should be set at 27 to 30 gauge needle may be used. So length could be 20 mm or a long 32 mm can be used, which is usually you are using it. But sometimes we go for a short one like 20 mm needle would be better. And the size 27 to 30 gauge size can be used there. Short needle may be used where the thickness of the soft tissue is less than 20 mm. That means if the child is very chubby child, thick masseter or chubbiness is there, if you use a short needle, you may not end up in giving a good LA. So in those child, you go for a longer needle. But otherwise around, you go for a short needle to give an LA there. The extra short, like 10 mm with 30 gauge needle, has been suggested for maxillary anterior injection. What do you mean by maxillary anterior? Your nasopalatine or if you want to give your posterior superior alveolar palatal side, if you want to give palatal injection, if you want to give, you can go for a short, extra short 10 mm 30 gauge needle has been, because that cause less pain compared to a long and longer needle. So you can choose the needle size and length in pediatric cases depending upon this condition there. And post-operative soft tissue injury, you should always tell them self-inflicted soft tissue injury can happen. So you have to inform them the patient should not chew or bite after a lay. Almost lip or cheek biting can happen, so that has to be addressed there. Now, one thing, bupivacaine is a long-acting LA. It is not recommended for very young child or physically or mentally disabled patient because of its long activity. Child who's cannot control their movements, or children who is physically or mentally, or very young children, we avoid bupivacaine because it is a long-acting LA. So that is because of the post-operative longer time of duration is there. Now, failure in local anesthesia in children, operator-dependent factors are there. What are the operator-dependent factors? A bad choice of the local anesthetic solution. So you choose an anesthetic solution which is not right for that age, and poor technique. You choose, I told you, a needle size, length, you chose the bad one. Now, patient-dependent factors, anatomical variations are there. What do you mean by anatomical variation? The inferior alveolar nerve going into the canal are different for different age group. So that you should know that. Presence of infection. If already infection is there in that particular area, if you inject, it may not work there. Psychogenic factors like anxiety, you may inject, but it is working, but patient is not feeling because of the anxiety that is present there. And the anatomical variation, as you all know, below 6 years, it is always, you should bend the needle towards downwards. The patient is age is below 6 years of age. At 6 years, it should be at the level of occlusion, and above 6 years, it should be always above the level of occlusion. So younger children should be always below. So the needle should bend downwards there. So you should have a proper knowledge about the growth and the neuroanatomy of the head and the neck for proper injection that has to be given. And there are proper dose management, dose, body weight and body index, body mass index to minimize the toxicity and prolonged duration of anesthesia. So the proper dosage should be there. Epinephrine is a relative contraindication in children with hyperthyroidism. You cannot give epinephrine in children with hyperthyroidism that is present there. Patient with a significant cardiac disease, child with cardiac diseases, dysfunction, diabetes, or those receiving MOA, right, cyclic antidepressants, because nowadays children are under stress. So if they are taking any of the psychogenic drugs, you should warn of giving epinephrine, and the local anesthetic vasoconstrictor should be considered. So you have to give an LA without a vasoconstrictor has to be preferred for that. And there are some newer drug delivery system like computer controlled drug delivery, like a van systems are there, where patients feel very less amount of pain. And there are needleless injection, but jet injections are available, which doesn't have any needle. It is just given for, especially for uh, your infiltrations. And even for block, you can give this jet injection, then you can give block so that patient doesn't feel about it, so that that anesthetize the area patient doesn't know. And electronic dental anesthesia is also there, where controlled anesthetic is given without. So if the question is what are the pediatric consideration that is given for a local anesthesia, so much to write about these questions, and I've concluded this starting from the post-operative complications, the dosage variations with LA, without with epinephrine, without epinephrine, the needle size that you have to select, and the this age differences, then the newer drug delivery systems like this. So much things that you have to consider when you try to give and local anesthesia for a pediatric age group. And now the latest things, there is intraoral lidocaine patches are available. That the patches comes like your any other patches. You apply this patch and wait for maybe 15 to 13 minutes. You wait, the patch will leach and it will anesthetize the area, and then you can inject with your LA, like infiltration or whatever if you want to give, and then do the procedure. So these are the pediatric consideration that you can give. Patches can be kept there. So mainly points to remember or to be written down is there's a difference between child and adult patient. The fear is one factor. One of the factor that keeps to consideration is the fear and anxiety of the child of the needle and injection terminologies and all. Second factor is the bone density. One density of the maxillary and the mandibular bone are different from child and adult. So there will might be a faster penetration because the bone density is less, blood supply is more, so you need less amount of local anesthetic solutions. So you can't use an anesthetic solution without an epinephrine or vasoconstrictor, because vasoconstrictor reduces the absorption of the lignocaine, which is the most toxic thing for the body. So that points has to be taken into consideration. And anatomical structure below occlusion, at the level of occlusion, above the occlusion, because of the needle and penetration of the needle, the size of the needle, the length of the needle. If the child is very chubby, we don't use short needles or thin needles, because the chubbiness, you may not reach onto the bone. So you might have to use a conventional long needle with a normal gauze and size there. The depth of penetration determines on that, and emotional aspect which are different. So these are the points that will be kept in your mind in a patient whom you want to give anesthesia. So pediatric consideration of local anesthetic has been asked as a short essay and short note, and covered under this in these points. So psychological, anatomical, and drug dosage, needle, position of the needle, and post-operative extraction complication also has to be mentioned there. So 6 to 7 points is mandatory for that in the case of a pediatric local anesthesia. So one more quiz. This is one of the last quiz. In a caries lesion in which caries has extended into dendine, which of the following zones contain infected dendine and is not capable for remineralization? I hope you understood the question. Once again, I will ask you the question. The question is, in a caries lesion, in which caries has extended into dendine, which of the following zones contain infected dendine and is not capable of remineralization? Is a normal dendine, subtransparent dendine, transparent dendine, turbid dendine, or aberrated dendine? Which among the dendine you can't remineralize? Again, in a caries lesion, in which caries is extended into dendine, which of the following zones contain infected dendine and is not capable of remineralization? Can I get the answer? Are you all gone to sleep? There are no answer I'm getting. Have you gone to the sleep? Normal dendine, subtransparent dendine, transparent dendine, turbid dendine, aberrated dendine. What is the answer? Oh, great, great. So many people now are responding. Maybe the net issue. So many people responding. Good, good. Yes, you are right. Roshni, you are right. The first person you have answered. Pavitra is the first person. Congratulations to Pavitra and Prajit Sinha. Right, the answer is turbid dendine. The turbid dendine is the one which cannot capable of remineralization, because normal dendine will definitely remineralize. Subtransparent, transparent dendine are affected dendine, so they will remineralize. Turbid is infected dendine, which cannot be remineralized. And aberrated dendine, as you all know, it's a sclerotic or your tertiary dendine, or those are sclerotic dendine. So definitely it is already highly packed, so they have no any chance of already highly mineralized there. So which dendine cannot be demineralized? It could be a turbid dendine, which is a infected dendine. All are affected or highly mineralized there. Now the next part. How many of you have used sausages, or you have used your sauces for putting into pizzas or thing? So when you use this sauce in your home for pizza, for burger, either a tomato ketchup or any chili sauce or any sauce bottle, what do you do in sauce bottle when you want to bring the sauce out of that bottle. What will you do to bring the sauce out of that? One option is you to press the bottle. If you press the bottle, you apply pressure, you press the bottle, the sauce will come down. Yes, I am getting answer. Yes or no? Yeah, press or squeeze. Second option is you shake it. You shake it. You shake it like this. You can see ping, ping, ping. It comes out. Yes or no? The sauce will come out. But if you do not shake it, it won't come out. It will be stable there. Even though the lid is open, you just hold it, it won't come out. But if you press it, it will come out, or you shake it, it will come out. So what is happening there is you are applying a pressure into this bottle, and that makes the gel, or that makes that sauce to become more liquid. Yes or no? So that is exactly, let's see that. Let's see this. Let's see this. If you squeeze like water, it will come out. But the moment you stop squeezing, you stop then and then. It doesn't happen then. The moment you squeeze, it come out, and the moment you do not squeeze, it stops out there. Fine. So it's come out there. Now exactly the same thing. Oh my God, my video is not there. My video is not there. Fine. Okay. Now exactly the same thing happens. Let's just listen to the bowl. A bowl of the same sauce is being kept. A bowl, the same sauce is being kept. Now I am putting a ball hard onto that. I'm pushing or putting a ball hard onto that. Just imagine what is going to happen. I just put a ball from high point. What is happening? Just see the slow motion of this. When I put a ball onto this solution, you can see how much it spread out. What has happened is the ball put a pressure, so that what happened to the gel, it became liquid. That is why it splashed. Otherwise, it won't splash. So what is basically happening is this gel is having a property called thixotropic property. And we have this property used in dentistry. It remains as a gel when no pressure applies. But when you put a pressure like pressing or squeezing or shaking, or you forcefully put a ball from top which has got a weight, it comes and hit onto this gel. The moment pressure applies, it becomes more liquid. That is called the thixotropic property and is used in dentistry. So introduction and definition of this is any oral healthcare products are liquid when squeezed and return to original state after removal of pressure. Wow, that's a definition of this. Any oral healthcare products that are liquid when squeezed and return to original state after removal of the pressure. Thixotropy is a time-dependent shear thinning property. Time dependent means the particular time you apply pressure, it will be thin. The moment you relieve the pressure, it will become thicker again. It reverts back. So time-dependent shear thinning property, it will become more thinner. Certain gels or fluids are thick or viscous under static condition. No pressure, they are become very thick and less viscous there. But over time, when you agitate, shake, apply pressure, they will become thinner. So time-dependent viscosity change that happens. That's called thixotropic property there. Example, cytoplasm and the ground substance in the human body are thixotropic. Your cytoplasm and the ground substance in the body are thixotropic there. Fisher space pen. You know, the people who go to space, astronauts who go to space, they want to write down something. They have something called Fisher space pen. And this pen looks like this. This won't write in normal environment, provided that a particular environment is been provided. This pen works there, and it costs you around 12 to 15,000 rupees for a pen. That is called Fisher space pen, and it follows this thixotropic property. Apply pressure, it will work on that condition there. So solder paste in orthodontics. Orthodontics, solder paste are there. use the electronic manufacture, printing process as thixotropic property in
Dr.
orthodontics.
Joby,
Yes,
Dr. Joby, very sorry, your video is switched off somehow. It's okay, but everything else is perfect. Slides are perfect, audio is perfect, but video is.
Binu, I can see that my video, I can see that is there is some issue there. I can see my video. Is it anything related to that? I don't know.
Yeah, it's kind of video is like switched off, but slides are perfect, audio is perfect, Dr. Joby. You can continue.
But I can see my video, Binu. Can anybody?
People are commenting that they can't see you, sir. But everything else is perfect. It's not a net issue. It is something else because slides are perfect. Audio is perfect.
Fine. Shall I continue?
Yes, yes, Dr. Abhi, go ahead.
Fine. So that's a clinical, the dental indication of this solder paste that we use in orthodontics has got this thixotropic property. APF gel in topical fluoride application in dentistry has got this property there. When you apply this, you have a property there. Toothpaste gel toothpaste, if you remember, that has got a thixotropic property exactly that we say. Orthodontic solder has got the APF fluoride are there, and thixotropic gel versus normal gel. If you can see that.
Parts, the gel stays in place. It's a 60-second acidulated phosphate fluoride that contains 1.23% fluoride ion. Smooth, creamy gel will not. One of the best parts, the gel stays in place. It's a 60-second acidulated phosphate fluoride that contains 1.23% fluoride ion. The smooth, creamy gel will not run. In fact, it thickens during treatment to prevent patient gagging or discomfort.
So you can see a thixotropic gel will stay there, but a non-thixotropic gel will drain out. So in fluoride application, the advantage is it stays inside the gel or the tray. It doesn't leach out too much like this. So patient do not has got this gagging, does not go into the throat or uneasy feeling. The patient, the advantage of that. So the principle here is gel, salt, gel. That means it remains as a gel. The moment you apply pressure, it becomes solution. When you remove pressure, it will become gel. That is the principle there. At rest on storage, it multi-point contact, high viscosity, it will remain as a gel state. Nothing can happen. Like a sausage. The sauce, when you keep inside, you bend it just like that, nothing happens. The moment you apply pressure, what happens that when you apply pressure, more force is applied like a biting one. It breaks down, viscosity goes down, it will become a solution, like a watery liquid it will become. And once you remove that, once you remove the force, it will come back to a same high viscosity gel state. So that is the principle of that thixotropic property in dentistry there, where you apply pressure, it will become liquid. So what is advantage here is a fluoride application. Exactly the gel, the tray which you show, it doesn't goes out of the tray, it stays inside the tray like a thick solution when it's at rest. Second thing is when you ask the patient, clinical implication, gel APF, especially in APF, the same applies for the orthodontic purpose like a solder. It also applies for multiple cases. But let us talk about pediatric dentistry. When you put this gel onto the pediatric tray, it will form like a hum, like a it won't flow initially. It doesn't flow. It will be like a conventional gel you put onto the floor. But you have to press the flange of the tray to make it spread. So that when you apply pressure, it will become liquid and it gets spread uniformly. Then once you keep this thing inside the patient mouth, you have to ask the patient to chew for a particular period of time. You have to chew. So when you apply pressure, it becomes liquid. So it goes into the interproximal area. This will ensure uniform spread of the gel into the interproximal for maximum caries protection. So you can see here the gel is applied and you have to press the tray like this so that uniformly it's spread. Otherwise, it will be like a ball because no pressure means it's like a round ball. It will remain there. Then you apply the gel, keep the high volume suction and tell the patient to bite. You can see that. See, ask the patient to bite 2 to 3 times. This spreads the gel into the interproximal area for maximum protection. Now, same thing applies when you ask the patient to use a gel form of toothpaste. You, whenever you're indicating a gel form of a toothpaste, patient takes the toothpaste like this. It will be like a bolus like this. And if you ask them to brush, they try to brush in the initial brushing only, the entire ball will fall into the mouth and patient might spit. So maximum benefit won't take place. That is why you ask the patient to press the ball into the bristles. When you put pressure, it become liquid so that it process goes into the bristles properly. And then the patient brush slowly inside the bristles. This gel comes out. So the 2 minutes brushing, which is recommended, this gel is available for brushing. So maximum benefit you will get that. So that is the reason for the gel form paste should always press into the bristles to avoid dislodgement during the first stroke of brushing them. So the last quiz for the day. How many 1.7 millimeter carpules of 2% lidocaine with 1 is to 10,000, 1 lakh epinephrine can be safely administered to a girl whose weight 25 kg? How many 1.7 ampule? That is, so your normal syringe, which are you 2 ml syringe, you take 1.7 ml only, nothing more than that you take. In that syringe, you are using a 2% lidocaine with 1 is to 1 lakh epinephrine. How many syringes can you give a child who is weighing 2.5 kg? Is it 1, 3, 2, 5, or 8? Can I get an answer? If you give me the answer, I will finish it. Last question, 5 to 10 minutes, done. What is the right answer for this? How many 1.7, how many syringes of 1.7 carpules can be given to a person with a 2% lidocaine with 1 is to 1 lakh epinephrine can be safely administered? Any answer? Any answer? Anybody want to try? A, B, C? Why don't you try? Why don't you try for a D5? Somebody's answered 5. Let me see. The correct answer is B, that is 3. Why? The maximum recommended dose for anybody is 4.4 milligram per kg body weight. Maximum recommended dose of LA is 4.4 milligram per kg body. So 25 kg is into 4.4 is 110 milligram is the maximum recommended dose for the child, because the child kilogram is 25 for the child. So 1 carpule or 1 ml, 1 syringe of 1.7 ml contains 34 milligram. Every time when you are taking 1.7 ml in a syringe, it contains 34 milligram of lignocaine there. So 110 divided by 34 is 3.2, or 3 would be the safest. So 3 syringes is the maximum injection that you can give for a child whose weighs 25 milligram to avoid toxicity there. So the last part is just a case discussion. A patient of 7.5 years of age with mouth breathing habits there. Lips are hypotonic. Every features of a mouth breathing is present in this child with malocclusion, with developing malocclusion there. So the patient is recommended to use a appliance called oral screen. All of you know that oral screen or vestibular screen is the appliance that we use this pen. So next part is inhibitory treatment, which is also called vestibular screening therapy, or use of oral screen as a habit breaking appliance is the next part, or screening therapy. It can be asked as a screening therapy or inhibitory treatment, but different authors call it that. But it's all the screening therapy done for a breathing patient. So your answer should contain introduction. Who introduced the vestibular screen is Neville in the year 1912. And what is it? It is a thin sheet of acrylic base material which is fit into the buccal and the labial vestibule of the mouth, which acts as a screen between the teeth and the surrounding musculature. It is also called as a vestibular screen. Okay, so basically it is called vestibular screen or oral screen. There is no difference between that. Many of other people say that oral screen and vestibular screen is different. But in literature, if you read, oral screen or vestibular screen are safe. It should extend into the buccal or labial vestibule. Now, the tricky thing is people say that vestibular screen is into the vestibule, oral screen is just 2 to 3 millimeter below the vestibule. That is why it is oral screen. If it is an oral screen, if it is like that, it does not perform any function. But in literature, tell me, in literature, there is nothing called 3 mm short of the sulcus or not extending into sulcus. It is recorded or done in such a way that it has to extend into the vestibule, fully extend in the vestibule, because it is a myofunctional appliance. It has to extend into the vestibule, myofunctional appliance. That is why it is called vestibular skin or oral skin there. So working principle is that it is a myofunctional, loose-fitting, passive appliance which harness the force of the muscles and keep the muscles away and allow the arch to development. So it's a myofunctional appliance there. See, skin works on two broad principles: force application. So you have to do an exercise, then it apply a force. If you do not apply any exercises, it just eliminate the force. That's it. So works on two principles: it apply a force, eliminate a force. So if you want this appliance to apply a force, you have to do muscle exercises. If you do not want this appliance to apply force, just to remove the forces, then don't tell the patient to do any exercises. So that is why it apply force application and force elimination. Force application means compressive stress or strain force is applied onto the appliance, and this appliance transfer these forces onto the arches and changes the development. Elimination means it acts as a screen. It acts as a screen and prevents the muscular forces, and so that is called the force elimination. So allow the dental arch to develop because it acts as a screen there. Uses of this appliance: the oral skin, vestibular skin, it is used in mouth breathing habits. It is used in thumb sucking habit. It is used in early management of class 2 development, distal occlusion, class 2, that is your distal step development in mixed dentition. It has been developed. Lip biting cases, patient with a continuous lip biting, tongue thrusting, and nail and cheek biting. These are the indication of a oral skin or a vestibular skin there. And clinical management of this appliance: patient should be asked to wear the appliance at night, 2 to 3 hours, and daytime. So complete night and 2 to 3 hours daytime. Patient is instructed to maintain lip seal during wear. That means patient should get the upper and the lower lip closed together, not open. That is not right. First few days, the patient is asked to have an irritation because of the new appliance has been kept. And there can be some irritation in the sulcus or the frenal areas. So that has to be carefully trimmed when the patient is being placed. And what are the modification of this appliance? Modification of the vestibular skin with holes. You can put holes onto this side. This is specifically indicated in patient with mouth breathers. Holes can be placed at the midline and you can reduce the holes. 4 to 6 holes can be placed and you can reduce the holes. Gradually, as a patient get used to it, you can reduce the holes. So these are the holes in the midline area you can put, and you can reduce the holes there. Now, this appliance, if you see, identify this appliance. Can anybody tell me what is this appliance in the chat box? What is this appliance? This red appliance, any modification of this appliance? Any modification? Is it called any modification? This appliance is called the Holtz modification because there is a ring. Any appliance, initial vestibular screen or oral screen doesn't have this Holtz modification. No holes, no ring. But Holtz, Dr. Holtz said that to do the myofunction exercise will be better, you can ask the patient to put a ring. So this ring is not to hold the appliance. This ring is to tell the patient, saying that your lips should come and touch this ring, so that patients can hold the lip, upper and the lower lip close together. While doing, they are indirectly putting a force because they are contracting the lip muscle, so they can hold it. And second thing, to do the myo exercises. So it is an appliance that doesn't eliminate, it also applies that apply forces while doing myo exercises. So that is called the Holtz modification. And what about this? Can you find out this appliance? What is this appliance? What is this appliance? What do you see this appliance? Anybody? Can you tell what is this appliance? This is, yes, double oral screen. Double oral screen, you can say. There's a screen and there's a guard inside for tongue thrusting habit also. So you can prevent the tongue thrusting habit also. And there are so many preformed tongue thrusting habits are there with the crib, with so many things are available. You can order in online also for young patient. You can do that with tongue guard. That is for double oral screen is there. Like this kind of double oral screens are also available there. So vestibular screen with lip and breathing exercises. You have asked the patient to do the exercises. Now your force application comes there. Till now force elimination is there. Now comes force application. You are applying a force. How you are applying? With the help of exercises like a monkey exercises, ballooning exercises, puffing air in the lips with the tug of war, to ask the patient to pull it out and all. And all these exercises should be done minimum 20 minutes per day, split it into 4 to 5. I mean 2 to 3 minutes at a time, split it into 4 to 5 minutes, makes into 15 to 20 minutes would be there. And treatment duration, minimum 20 months will require to correct the habits there. So this patient who had the habit of mouth breathing, treated with entirely with the screening or inhibition therapy with pulse modification, and she is now after the treatment, she is almost in 11 years. When she came, she was 7.5 to 8 years. Now she's almost 11 years with the screening therapy alone. 15 months into treatment, you can see the difference there. She's almost into 10 to 11 years of age with the screening therapy there. So that is all. I'm done. So I wish you all the best. Since I told you this is already done, it's a part of me to wind up. Thank you so much. The exam alert session will be successful and productive. And we selected the faculties, we selected the questions, subjects such a way that it is useful for you. Many of these questions which I already discussed now is as come as a question already, but this will help you to rectify and apply when the practical sessions comes there. So I'm done. Thank you so much. I hope I have done. If any more doubts are there, you can ask me. And I do not understand still my video is not being seen there. Dr. Binu, are you there?
Yes, Jabi, thank you so much. Let me see whether some questions are there. Not at this point of time. Anybody has any doubts regarding these topics, please feel free to put in the chat box now. Otherwise, you can even put in the corresponding WhatsApp groups you are in. Dr. Jabi will definitely address that these days. So feel free to do that. Any doubts? Nothing, I guess. Okay, so once again, thank you. Dr. Jabi, can we wind it up? No
Yes.
doubts, all the comments of what you asked. Yeah. So we can wind it up, right, Dr. Jabi?
I have one question that is asked, sir, which is the best book or books to refer used in clinical application pedodontics? If you ask the clinical application part in pedodontics, doctor, there are multiple books. Welbury, Richard Welbury is one textbook where you can get a lot of clinical indications, clinical case scenario are there. And there is one more textbook where you get clinically oriented pedodontics and orthodontics. One question. If you come to me directly, ask me, I will send you the link of that book. And that is also a very good book for clinical application of pedodontic practice. That is that.
All right. So thank you so much, Dr. Jabi, and we are officially concluding the first round of exam alert.
Second round, Bill.
No, I mean exam alert for the final year is done. The whole final year subjects in 2 sessions for each subject successfully completed. A lot of messages we got that, sir, many questions the same as what we discussed in class, this, that. So happy to know that. And those who are still to give exams, all the very best. All the very best. Okay. Do well. That's it, Dr. Joby. Thank you very much. And all the candidates, thank you so much for being here all this time. Good night. See you.